We are live in 3, 2, 1. Please start, sir. We are live.
So very good evening to everyone, and it's a great pleasure to welcome you for Oncology 2022. We have a pleasure to welcome you all for the day 2, which is specifically focused on the treatment and management of lung cancer. It's an honor and privilege to welcome Dr. Ashwin Phillips, Associate Professor and Head Medical Oncology, Christian Medical College and Hospital, Ludhiana, Consultant at Medical Oncologist at Mohanday Oswal Hospital, Ludhiana. So good evening, Dr. Ashwin. The stage is set. We welcome you for your introduction and setting the context, please. Over to you, sir.
Thank you so much, Tarun, and thank you so much for giving me the introduction. At the onset, I would like to thank all of you for being a part of this event. And the last 2 days, the second day today has been good. And the first day we discussed about hematological malignancies, and today we focused on lung cancer. So with one of the reasons of discussing lung cancer is that, as all of us know, most of the recent advances and exciting things have happened. It's happened in the field of lung cancer. And when I was training, we found it. I never expected it to be so different. By the time I passed out and I'm practicing, there's a lot of differences. So without wasting much time, I would like to introduce the chairpersons, and we have 2 eminent chairpersons, and I want to thank all the esteemed faculties who have taken part in this program as well. So with the first chairperson, I would like to introduce Dr. Rajeshwar Singh. Sir is a senior consultant and medical oncologist who's based at Paras Hospital, Panchkula. Sir has an illustrious career, and he's also an alumni of Cancer Institute, Adyar, and sir has also been from the armed forces as well. The second chairperson is Dr. Aman Arora. Sir is one of the first medical oncologists to practice in Punjab, and I have the privilege of actually working with sir, and sir has been a mentor to me at any point of time. So with that, I would not waste much time, and I would give it over to the chairpersons to take the meeting forward. Thank you, sir. Rajesh, sir, it's over to you.
Thank you very much. Firstly, I thank Dr. Philip for giving this opportunity. And now we move on to our first presentation. And we have with us Dr. Kunal Jain, who is Assistant Prof in Medical Oncology at DMCH, Ludhiana. So very aptly put up that he's an all-rounder, very clear thought process, and it is always fun to listen to him. I'll request Dr. Kunal Jain to speak on third generation TKI upfront. Dr. Kunal.
Yes, sir. Thank you. Thanks for the introduction. So good evening, everyone. Can I share my screen? Okay.
Yes, sir.
So I hope the screen is visible. So my job for the next 15 minutes is to discuss about third generation TKI upfront, and focus being on osimertinib. So what is the right approach is what we are going to see. And this is the overview of my presentation. Just briefly about epidemiology, everyone knows lung cancer globally accounted for about 11% of all new cancer cases, second only to breast cancer. And it was contributing 18% of all cancer related deaths, which is the maximum number of deaths related to any cancer. And if we talk about India in 2020, close to 72,500 new patients of lung cancer were diagnosed and 66,000 deaths, which contributed about 7.8% of all cancers. And highest incidents were reported from Mizoram in both males and females as per the ICMR study. We know and we see in our practice that majority of patients present with advanced disease. I would say in our practice, nearly 75 to 80% of patients present with metastatic disease, and majority are non-small cell lung cancer. And as per the data, with increasing age, we know that the survival dips significantly, and for stage 4, the survival is around 5% or less. But in contrast to this, if the patient has activating mutation, which is most notably EGFR mutation, the survival in those patients is 3 times as compared to the normal conventional lung cancer patients. So that is the importance that we have come to know over the last few years, as Ashwin was mentioning, that during his training, things have changed. So you can imagine how things would have changed since Dr. Rajeshwar was practicing or since I started doing oncology. So all patients used to get gemcitabine, carboplatin, or some of the platinum doublet, and then pemetrexed came while I was doing my training, and then these TKIs were new during that time. So in our practice, we all do mutation analysis for patients, especially non-small cell, non-squamous histology. When we see them in our clinic, we do mutation analysis for EGFR, AL, CROS1, and BRAF, and also subject these patients to PD-L1. So these are the 4 mutations where we have targets available. There are other mutations also of significance, but right now we don't have targets for all of them except probably MET. So I think these are the 4 which we are regularly doing, and we know that once EGFR gets mutated, it signals continuous downstream signaling pathway, which causes cell proliferation, transcription, protein synthesis, and cell survival, and takes away cells from apoptosis, which is what is basically implemented in malignancy. If we talk about osimertinib, it is active against the common mutations, the L858R and exon 19 deletion, and also against one of the drugs which is active against T790M mutation, which is really challenging to manage. And it has nil or no activity against wild type EGFR. Again, in tabular form, just to depict what are the highlights of 3rd generation TKIs, the prototype being osimertinib. This is an irreversible, it has irreversible EGFR binding. It has activity against EGFR T790M mutation, and it has good blood-brain penetration, which is again one of the features which I'll be subsequently showing in the slides, and it is of importance because a lot of these patients have brain metastasis, and we need active drugs which can cross blood-brain barrier and act at that level. So with this background, in the next few slides, I'll discuss about the FLORA trial, which was a randomized, I'm sure everybody knows about this trial, just a revision, a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as first-line treatment in patients with locally advanced or metastatic EGFR mutation non-small cell lung cancer. So this study was done in 29 countries and 132 sites. Both Asian as well as non-Asian countries were involved. When I say Asian, it was not India. So key inclusion criteria were pretty standard, and stratification was done as per the mutation status and race, Asian versus non-Asian. So patients were randomized 1:1 to either osimertinib 80 milligrams daily or the standard of care EGFR TKI, which could be either gefitinib or erlotinib in the standard doses. And patients were followed till progressive disease. Every 6 weeks, they were assessed radiologically with RECIST 1.1 assessment. And other notable thing in this trial was in the control arm, if the patients progressed and they were found to have T790M mutation, they were allowed to cross over to receive osimertinib because it was proven to be of benefit in that population. The primary endpoint of this trial was progression-free survival and overall survival, and a lot of other secondary endpoints were there. So patients were pretty well balanced in both the groups. Majority were females, Asians, never smokers. Nearly 20% had CNS metastasis at study entry, which is 1 in 5 patients, which is quite significant. All patients had good performance status, majority with stage 4 disease, adenocarcinoma histology, and majority with exon 19 deletion, which is what we also see in our practice. So the progression-free survival as assessed by investigators was significantly longer in patients who were in osimertinib arm as compared to standard of care. PFS was close to 19 months with osimertinib as opposed to 10 months with standard of care, which is what we have seen with the previous trials with gefitinib, erlotinib also, that PFS remains just a year earlier, less than a year, and overall survival close to about 2 years or so. So very impressive hazard ratio of 0.46, which translated to 54% reduction in risk of progression or death as compared to the standard TKIs. So the important numbers to remember of it in 19 months of PFS and 10 months with standard of care. So PFS across subgroups, you can see almost every subgroup showed benefit. Everything was to the left of unity. And Asian, non-Asian, there was much higher benefit with non-Asian subpopulation as compared to Asian, but even in Asians, the benefit was significant. I'll show the slide subsequently about that Asian subgroup also. So the response rates were kind of similar, which meant that even the first generation TKI did show initial response, but what was important, what becomes important in such a situation when response rates are good with both the agents is duration of response. So which is measured from the time of first assessment when you document response till progression. So there was near doubling of duration of response with the osimertinib as compared to standard of care. 17.2 months with osimertinib versus 8.5 months with the standard of care. So overall survival was also significantly longer, although it was just the p-value was just significant 0.04, hazard of near 0.8. So overall survival of 38 months, in excess of 3 years, as compared to 31 months with EGFR TKI. So this is probably the first TKI to show significant overall survival independently as compared to the comparator arm. So most of the other TKIs have definitely shown progression-free survival, but overall survival has been found wanting in most of the studies. And again, notably here that a lot of patients did, I think close to 35 to 40% patients did cross over to receive osimertinib in the other group also. So adverse events, there was nothing notable, especially in the osimertinib arm. It is consistent with the side effects that we see with all other TKIs as well. And majority of the side effects numerically, if we see the percentage wise, most of them were less than the other TKIs. Serious adverse events were also less. Grade 3 or more were less with osimertinib as compared with standard of care. Adverse events leading to death were about 2%, and these included infection, low respiratory tract infection mentioned as pneumonia also. Some had one patient had myocardial infarction. There was some cerebral ischemia. So there were 6 patients which had death related to osimertinib, which was again less than standard of care. And any adverse event leading to discontinuation of treatment was seen in 13% of patients with osimertinib as compared to 18% with the standard of care. So I'll come to the summary of this slide later, but just highlighting the CNS efficacy, as I mentioned earlier, that lung cancer patients in general have a higher propensity for brain metastasis. But if we come to the EGFR mutation subset, the incidence of brain metastasis even double as compared to patients with wild type EGFR. And in this trial, because it included patients with stable CNS mets, it showed that PFS did not significantly differ, or the magnitude of benefit remained even if the patients had the CNS mets. So you can see the graph on the left is showing patients with CNS mets. PFS was 15 months as compared to 9.6 with a good hazard ratio of 0.47, whereas patients without CNS mets, obviously they had a better PFS as compared to patients with CNS mets. But it did show benefit in that subgroup also. And if we talk only of CNS PFS and we forget about the rest of the metastatic sites, even in that, a median PFS was not reached in osimertinib arm as compared to standard of care, where the median PFS reported was 13.9. Again, highlighting the fact that this is an active drug in CNS. And if we now compare it with we have already seen the comparison or its comparison with the first generation TKIs, geftinib or lorlatinib. So how does it fare with the dacomitinib? There is no head-to-head comparison, but just showing the two trials, although scientifically, if we, in truest sense, this is not something that we can directly compare, but at least some points we can see in Archer, which was the study for decometinib. Initial 6 months, for PFS, the graphs were kind of overlapping. And if you will see the overall survival, it was something like the IPAS trial. The comparator arm of geftinib was doing better in the initial 6 months, and then decometinib took over. So overall PFS was 14.7 as compared to 19 months with Flora, where it showed immediate separation. And if we see the overall survival, it was about 34 months in this study, and it was 38 months with osimertinib, which it showed significant benefit. In this trial, it was designed in a way.
Dr. Kunal, sir, sorry to interrupt. A fantastic presentation. Last minute to conclude.
Sure. Yeah. So this showed in this trial, it was built in such a way that if there was no significant difference in overall response rate, they would not be reporting the overall survival difference. Similar was the case with the afatinib, where it was compared with geftinib, and there was no significant difference in overall survival or PFS. And this is basically showing the difference in safety profile, where again osimertinib scores over other TKIs. So concluding my talk, for the first time in evolution of EGFR TKIs, osimertinib translated PFS to a significant OS benefit. It has a median PFS of 18.9 months and OS of 38.6, which is significantly higher than the first and second generation EGFR TKIs. It has shown efficacy in patients with CNS mets, with fewer CNS progression events. Fewer and less severe adverse events gives osimertinib a better safety profile than other EGFR TKIs. So this is the new standard of care for first-line therapy in patients with EGFR mutant advanced non-small cell lung cancer. But the biggest challenge that we face in our OPD when we are seeing the patients is the enormous cost of this drug. Although it has come down, as per the company, they have significantly reduced the price, but still it is quite significant in my view. 1.2 lakhs per month is a huge cost for, I think, common people in India to afford. So I think that is where most of the decisions are made in terms of affordability. Other than this, from my point of view, other two first-line options in somebody who's very fit will include chemotherapy, paclitaxel, carboplatin, or pem-carbo with geftinib, or erlotinib and bevacizumab, somebody who can afford something in between osimertinib or the other TKIs. So with that, I'll end, and I'll...
Thank you, Dr. Kunal. That was a lovely presentation. Basically, you brought the main issues. It's a wonderful drug which gives not only the good hazards in PFS, and as far as the CNS mets also, this is very important, because in practice also we see more than 10 to 15% of our patients coming with CNS metastasis, and we need not do radiotherapy. And we know that the side effect of radiotherapy itself, and of course, whether we are using this or we are using afatinib, I found we can carry on for many months without giving radiotherapy. So it is a wonderful drug, and only problem is the slight diarrhea which occurs with that when we have to modify our doses. But I have seen even with modified doses, the effect are very good. Thank you very much for your lovely presentation. And if there are no questions or issues, I request my co-chair, Dr. Raman, to take over, please.
Thank you. Thank you, Dr. Rajesh. And now I have to request our next speaker, Dr. Javil from Srinagar, to present his talk. Dr. Javil, please.
Thank you very much, Dr. Ashwin and Dr. Rajeshwar sir and Dr. Raman sir, for giving me opportunity to present data of now third generation. Are my slides shared by there, or I have to share my slides?
You can share your slides, sir.
Okay, thank you. So the stage is well set, sir, that Dr. Kunal gave very good presentation about third generation TKIs in the form of this anti-EGFR treatment. Now I have to be slightly away from idea. Again, I have to discuss about the third generation. Now we are discussing the lorlatinib third generation ALK inhibitor. So I will be not discussing about the epidemiology of the lung cancer, which has been taken care by Dr. Kunal very well. So I will directly go to my talk. So about the Indian data, what we have availability about the this ALK gene rearrangement lung adenocarcinoma. So we see across all the studies that ALK gene rearrangement in lung adenocarcinoma is seen in around 1.6 to 11.7%. And in my experience also, I see around 4 to 5%. And what is the paper that has been presented by this Amarjit Bala and Navneet Singh? So they have seen that ALK mutation was seen in ALK, this rearrangement was seen in 7% of the adenocarcinomas. And we know that as Dr. Kunal also highlighted that the survival in stage 4 is very, very limited now. Since these driver mutations came and the drugs came into the market, the overall survival in stage 4 disease, and you can see from this graph, the median OS of 81 months, that's 6.8 years. So we are now looking for more and more years of in this stage 4 disease. So the first drug that was approved for ALK inhibition was the crizotinib, that was from the Pfizer. So are there any prototype patients that these ALK positive lung adenocarcinoma patients have? It's not, we cannot say it's a prototype, but most of these patients, they are having a minimal or no smoking history. And yes, adenocarcinoma is their histopathology, and they are younger than that of the other other patients. And one important thing is that earlier studies that showed that there was lack of concurrent driver mutations, that is EGFR mutations. But we see nowadays dual mutations, but these are not uncommon, but still we see these concurrent other driver mutations. And brain metastasis is common in patients who have ALK positive non-small cell lung cancer. It has been seen in many studies as 30%, as the tone of 30% at diagnosis. And with the addition of the first generation ALK inhibitor, so these brain metastases increase. So the prevalence of the ALK positive non-small cell, we have 3 to 5% in unselected non-small cell lung cancer patients. And if we talk of EGFR wild type patients, it is seen in 33% of the patients. So there has been the development of these ALK inhibitors over the time, and since the discovery of the AML4 ALK translocation in 2007, we are now in the third generation. And this is the first time that in 2021, the US FDA gave approval to lorlatinib in frontline. Before that, it was approved in third line or second line. So these ALK rearranged. So we see now the first generation like crizotinib, second generation ceritinib, alectinib, and brigatinib, and now third generation lorlatinib. So what do we see that potency increases once the generation change, that from first to third generation potency increases towards the ALK inhibition, and the third generation have more activity over the acquired mutations, what a patient acquires during the process of the treatment. And third, that there is better penetration into the CNS once from first generation to the third generation. So that's the difference from first generation to the third generation. And here, the first generation, that crizotinib, which was approved actually from the profile 1001, this was the beginning of the ALK inhibition. And in that case, in that cohort of the patients, expansion cohort of non-small cell adenocarcinoma patients, objective response rate was 57% and disease control rate was 87%. And median PFS was 9.7 months. And these were those patients who had received multiple lines of the treatment earlier on in the form of chemotherapy. So the first approval of the crizotinib came in second line once it was tested against the second line chemotherapy in profile 1007. And you can see the crizotinib gave 7.7 months of median PFS and versus 3 months with the second line of the chemotherapy with a hazard ratio of 0.49 favoring crizotinib by decreasing the progression of the disease in 51% of the patients. Then it was tested for the first line against the standard of care chemotherapy. And here again, you can see the median progression-free survival was 10.9 months versus 7 months. And the again, hazard ratio was further down, that was 0.45, that it decreased the progression by 55%. Then we got subsequent approval of other ALK inhibitors in the form of second generation like seratinib. And we have the SN4 data here, and you can see the progression-free survival is 16.6 months versus 8.1 month for the crizotinib. So there was doubling of the progression-free survival with second generation TKIs. And from the alectinib ALEX trial, the progression-free survival has been 34.8 months. And this updated results of the ALEX study. So 34.8 months versus 10.9 month median progression-free survival. So came this ALTA first line data of the brigatinib versus crizotinib. So here again, second generation ALK inhibitors had edge over the first generation crizotinib. So 24 months progression-free survival versus 11 months with a very good hazard ratio less than 0.5. So what was the need for development of lorlatinib, and why we are discussing the lorlatinib today, and is there any peculiar mechanism of action for the lorlatinib? So the importance of the lorlatinib lies that one is it has an highest brain penetration, and we see that with the advent of the the passage of the time, these ALK positive non-small cell lung cancers, they get more brain metastasis. So the drug does not penetrate blood-brain barrier very well. So this lorlatinib has the highest brain penetration. And the second important is that it overcomes the acquired resistance to ALK inhibitors. So whatever the ALK mutations we get, it is taken care by the lorlatinib most of the time. So double mutations are taken care by the lorlatinib, but the triple mutation, while the patient develops triple mutation, that time there is a resistance to lorlatinib as well. So it has effective CNS penetration and retention, and it binds with high affinity to most ALK resistance mutations. So this is the real world data again from the India that was presented by the Kumar and Prabhai sir. So here you can say that this study, patients had brain metastasis at the beginning, 59%, and median follow-up of this study was 16 months, and disease control rate was 73%. So one important thing is here that clinical benefit, 73% of patients had clinical benefit with lorlatinib in ALK positive, ROS1 positive mutations. So what's the need of this changing the generations? And once you see that patient is on the first line or first generation ALK inhibition, they develop acquired mutations. And once they develop double mutations, and they are not sensitive to second generation as well. So that time you have to give third generation TKIs, third generation in the form of the lorlatinib. So we have two types of the ALK, these mutations, one variant 1 and variant 3. Variant 1 is taken care by the second generation, but variant 3 are not taken care by second generation as well. So it is the triple mutation basically when we can say that patient is now resistant to lorlatinib, that is third generation ALK inhibition. So we now one of the important thing is that where to choose a lorlatinib, which line you want to give lorlatinib. Is it that you have to put it there once second generations fail and you will give the lorlatinib as third line? See here that there is a study, one of the study that has been quoted here, that the number of the TKI lines that have been given before and the lorlatinib and what will be the progression-free survival. If we give third line of lorlatinib as a third line, the progression-free survival has not reached in this study, median progression-free survival. If we give in fourth line, it is 11.2 months. If you give in fifth or sixth line, it will be 6.5. So with passage of time, if we give this drug, if we administer this drug later in the course of the disease, the median progression-free survival benefit will also decrease. So there came the ground study data that what was the eligibility is that it has a stage 3 patients, stage 4 patients, and prior they had not received any kind of treatment, and was randomized against the same crizotinib as the first line. So here the primary endpoint was the progression-free survival. And you can see that the baseline characteristics which were present in both the arms, they were same, matching. And one important thing here, you can see progression-free survival at 12 months. 78% were without progression in lorlatinib arm versus 39% in crizotinib arm. And median progression-free survival was not achieved in lorlatinib. They were still continuing with the benefit versus 9.3 months. And one important thing was that they had a very good hazard ratio, that is 0.28. And from the investigator point of view, that he gave hazard ratio of 0.21. And again, 80% of patients were progression-free at 12 months. So one important thing is from this Foster plot that hazard ratio was 0.5 lesser in lorlatinib arm than crizotinib, and each and every parameter was benefited by the lorlatinib. More who had intracranial disease, their hazard ratio was less than 0.25, and those who were non-Asians. So again, intracranial response, that's very important for the lorlatinib because it has the highest penetration. And we can see that intracranial response here, 71% had this intracranial complete response versus 8% with the crizotinib. So that is highest. And 83% had intracranial response. So complete response was seen in 71% of the patients. And the median time to progression, again, it is not reached in the lorlatinib arm versus it is 16.6 months in the crizotinib arm with a very good hazard ratio. I have not seen hazard ratio like this, 0.07. So overall survival, basically it is almost same for all the second generation TKIs. And here the hazard ratio versus with the crizotinib is 0.72. Adverse events were equal. And the most common adverse event was the hypercholesterolemia, hypertriglyceridemia, and edema, and rest were manageable, and it improved the quality score as well versus crizotinib. So the conclusion of the study is that lorlatinib resulted in a significantly longer PFS, significantly higher overall and intracranial response rates, and improved global quality of life compared to crizotinib in first line. And lorlatinib intracranial response rates are 82% with complete responses of 71%. The safety profile is similar in both the studies, and these results support the use of lorlatinib as effective first-line therapy for patients with advanced ALK+. If you do the comparison of all these studies, and you can see the lorlatinib has a hazard ratio of 0.28 as far as the progression-free survival is concerned, with 71% complete response rates intracranially. And
Javed, please, for your time, please.
So conclusion of this meta-analysis where all these second generation TKIs were compared, that the PFS, our results indicated that the lorlatinib was the best treatment choice for patients, the ALK inhibitor naive or untreated patients. So this is our NCCN guideline also mentioning the lorlatinib as a first line. So I will run these slides. So the important thing is here now that lorlatinib. So where can we place the lorlatinib? We have not reached it in the progression-free survival. It has not reached it in CROWN study. So it is biggest, one of the proponents that we can switch this patient. We can put these patients on upfront lorlatinib, and other than respective that a patient has an affordability. Otherwise, second generation followed by the third generation. So I conclude with this. Thank you.
Dr. Javed, thank you very much for a very nice presentation. I appreciate your clearing about the doubts and about use of lorlatinib as first line. Of course, it needs to be compared with the second line rather than third with the first one. once you have the best line available. In time to come, we will know more about it. Thank you very much. I appreciate your presentation. And now I hand over back to Dr. Rajeshwar Singh for invitation to the next speaker, please.
Thank you, sir. And now we move on to the immunotherapy part, and we have with us Dr. Gupta from my hometown, Jammu. He's in Batra Medical College. He's a medical oncologist there, and he'll be talking about atezolizumab in first-line treatment of lung cancer. So, Dr. Gupta, please.
Is somebody sharing slides for me? I'm not able to share from my side. Okay. Thanks, Dr. Rajeshwar, sir, for the kind invitation. I think I am audible.
Yes, yes.
Okay. So my job is to speak on atezolizumab monotherapy in first-line metastatic non-small cell lung cancer. I am PAR 110 trial. So next slide, please. Okay, so we can see there is an unmet need in the treatment of patients with metastatic non-small cell lung cancer with no actionable biomarkers. On the left side of the slide, we can see that the targeted therapies have definitely improved the outcomes in patients with metastatic non-small cell lung cancer, as has been shown with the presentation of Dr. Kunal and Javed sir. Targeted therapies have certainly improved the outcomes of the patients with non-small cell lung cancer compared to chemotherapy. And the molecular profile, this is a French cooperative thoracic intergroup study, and it says that in their data, they've they could find only EGFR 11% and ALK around 5%, and a sizable population of patients were there who didn't have any actionable biomarker. So maybe PD-L1 is the target to hit in these patients. Next slide, please. So we have three global phase 3 atezolizumab trials in the first-line treatment of metastatic non-small cell lung cancer. IMPAR 110, 130, and 150. 130, 150 being the earlier ones. And the major difference from those trials was that they included only non-squamous histology, and atezolizumab was combined with chemotherapy and compared with chemotherapy. But in IMPAR 110 trial, both non-squamous and squamous patients were enrolled, and atezolizumab monotherapy was compared with chemotherapy arm. And the key question that was supposed to be answered in this trial was, is atezolizumab monotherapy a better agent than chemotherapy in PD-L1 selected chemotherapy naive patients? Next slide, please. So IMPAR 110 enrolled, as I said, squamous and non-squamous both patients, and atezolizumab monotherapy was compared with the platinum agent plus pemetrexed or gemcitabine in the first-line metastatic non-small cell lung cancer. Next slide, please. So the study design of the trial was like, it included stage 4 non-squamous and squamous patients. The patients had to be chemotherapy naive. They had to be PD-L1 selected. We had basically three types of PD-L1 selected patients. It was TC3 or IC3, which means high PD-L1 expression, more than 50% in the tumor cells or more than 10% in the immune cells. Then we had the second category of the PD-L1, which was high to intermediate, which means more than 5% on the tumor cells or more than 5% on the immune cells. And then it was any PD-L1 expression, which means more than or equal to 1% of PD-L1 expression, either on tumor cell or immune cells. Now, of course, the patients had to be EGFR ALK negative, and they were not supposed to have CNS metastasis. Patients were excluded from the trial. Stratification was done based on sex, ECOG performance status. Only performance status 0 and 1 were enrolled. Histology, both squamous and non-squamous were enrolled. And PD-L1 expression I just described. And the patients were tested on the SP142 platform, as well as they were also tested on the Ventana SP263 and the DECO22C3 platform. And they were equally randomized between the immunotherapy arm versus the chemotherapy arm. In the immunotherapy arm, the patients were treated till progression of disease or loss of clinical benefit. And the primary endpoint of the trial was overall survival in the wild type patient population. There were few key secondary endpoints also, which were the investigator assessed PFS, overall response rate, and duration of response as per the RECIST 1.1 criteria. Next slide, please. Now, the study design was slightly different in IMPAR 110 in the fact that it had a hierarchical statistical testing plan. The primary endpoint of the overall survival was tested hierarchically in the following order. In the first, in the high PD-L1 expression, if the primary endpoint was met, then in the TC2/3, or then in the subsequently in the any PD-L1 expression. This was primarily done to control for the overall type 1 error rate at a two-sided significance of 0.05. So only if in the three arms, if you can see on the left side, the primary overall survival was met, then only the secondary endpoint of PFS will be formally tested, only when the primary endpoint is positive among all three populations. But the primary endpoint of overall survival was actually met only in the first arm, that is the high PD-L1 expression. Therefore, the overall survival for this high or intermediate PD-L1 expression was not formally tested. We have the numerical data, but that's not statistical data. And the PD-L1 expression in any PD-L1 expression arm, the overall survival was not formally tested. Next slide, please. So the prevalence of PD-L1 expression was very much similar between the treatment arms. The high PD-L1 expression was seen in around 1/3 of the patients, which is the more than 50% of the tumor cells or more than 10% of the immune cells. The high intermediate PD-L1 expression was seen in around 58% patients in both the immunotherapy and the chemotherapy arms, and any PD-L1 expression was as expected to be around 100% in both the arms. Next slide, please. Now, demographics and the baseline characteristics were well balanced between all the three arms, in the high PD-L1 arm, in the high intermediate arm, as well as the PD-L1, any PD-L1 expression arm. Next slide, please. Now, coming to the primary endpoint of the trial. Now, in this slide, in the high PD-L1 expression group, we can clearly see the early separation of the curves, and the median overall survival in the atezolizumab arm was far better as compared to the chemotherapy arm. And the hazard ratio was around 0.59, and p-value was significant. And this was the interim analysis or the primary analysis, which was presented in the ESMO 19 in the abstract form and later published in the NEJM in 2020. So this was the primary analysis. Now, what happened with, next slide, please. So when we study this forest plot, overall survival improvement was seen in all key subgroups with atezolizumab, be it the 4 stratification factors, male, the demography wise, the current tobacco user or previous tobacco user, squamous, non-squamous, and performance wise. So the hazard ratio was 0.59, and the median survival was around 20 months versus 13.1 months. So what happened after longer follow-up? So when the updated analysis were presented by Herbert et al. At the World Conference on Lung Cancer in 2020, and when the median follow-up was extended till 31.3 months, still the updated exploratory analysis of overall survival in the high PD-L1 expression wild type population continued. Overall survival improvement was observed with atezolizumab versus chemotherapy. The median overall survival was still around 20.2 months versus 14.7 months. Next slide, please. Now, something about subsequent cancer therapies. When OS interim analysis was done, you can see only 2 patients, that is 1.9% patients, they switched to some other form of chemotherapy, whereas in the chemotherapy arm, 29.6% patients subsequently shifted to subsequent cancer immunotherapy. In the updated overall analysis, as high as 35% of the patients in the chemo arm then subsequently received the next line cancer immunotherapy, which means 1/3 of the patients had actually switched. So this is that RPSFT method. This is rank preserving structural failure time model. So what change, this method is basically used when we analyze overall survival when there is a switching of cancer therapies. So even after switching of cancer therapy from chemotherapy to immunotherapy, the overall survival hazard ratio still favored atezolizumab versus chemotherapy. That is what this RPSFT method showed us. Next slide, please. Now, what happened to the high intermediate group, that is the TC 2/3 or the IC 2/3 group? At the interim analysis, the overall testing boundary was not crossed, and therefore the hazard ratio was 0.72, and atezolizumab showed a numerical improvement over chemotherapy in median OS. But as I said, as per the statistical plan, this was not statistically relevant, but numerical gain was definitely there. The median OS was 18 months versus 14.9 months, and this is a median follow-up just 15.2 months. Next slide, please. Now, what happened in the any PD-L1 expression group? So here also, it was not formally tested because OS in TC 2/3 or IC 2/3 did not cross the testing boundary. So here we can see in any PD-L1 expression, which means a low PD-L1 expression group, the worms are somewhat overlapping, and hazard ratio is 0.83. So atezolizumab did show a numerical improvement of improvement in median overall survival of 17.5 months, but it was not formally tested due to the testing plan of the trial. Next slide. Now, what about the PFS? As I said, PFS was not formally tested due to the hierarchical testing plan, but yes, there was a clinically meaningful 3.1 month improvement in median PFS with atezolizumab versus chemotherapy. Median PFS in the high PD-L1 expression group was 8.1 months, whereas it was just about 5 months in the chemotherapy arm, and hazard ratio was 0.63, and p-value was significant, but it was not the statistically tested. Its numerical gain is definitely there. So what happened with the updated analysis? There continued to be a clinically meaningful improvement in PFS with AT arm versus chemotherapy arm. Now, studying about the overall response rates with atezolizumab versus chemotherapy. In the high PD-L1 expression group, the overall response rate was certainly better with the chemotherapy. With the immunotherapy, it was around 38.3% versus 28.6%. Now, what about the median duration of response? It was not achieved till analysis was done in the immunotherapy arm versus just 6.7 months in the high PD-L1 expression group. What about the high intermediate and any PD-L1 expression? Next slide, please. In the high intermediate and any PD-L1 expression group, overall response rates in the atezo versus chemotherapy arm were numerically the same. They were not statistically different, but median duration of response was not achieved in the interim analysis. Next slide, please. So at the updated analysis of the high PD-L1 group, overall response rate was still improved with atezolizumab versus chemotherapy. Median duration of response was around 39 months versus just 8.3 months in the chemotherapy arm. While as at the updated analysis, median duration of response was reached in all the groups, and overall response rates were, however, similar to the interim analysis subgroups. Now, when another good thing about this trial is that they not only performed this IHC testing on the SP142 platform, they also did it with the DACO22C3 platform and SP263 platform, and they found a very high level of concordance among patients with high PD-L1 expression. And as we can see, the benefit of atezo was seen in all the platforms. Now coming to the safety analysis, atezolizumab demonstrated a favorable safety profile as compared to chemotherapy in the IMPAR 110 trial. The all grade adverse events were around 90% in the immunotherapy arm versus 94% in the chemotherapy arm. But grade 3 to 4 adverse events were like 30% in the immunotherapy arm, whereas in the chemotherapy arm, they were 52%. And class-specific immune-mediated adverse events, they occurred in about 40% patients in the immunotherapy arm versus 16.7% patients in the chemotherapy arm. But grade 3 to 4 were just about 6.6% in the immunotherapy arm versus just 1.5% in the chemotherapy arm. So the safety profile for the atezolizumab monotherapy arm is consistent with the known safety profile of atezolizumab, and no new or unexpected safety signals were identified at the primary analysis. Next slide, please. So all-cause adverse effects, which happen to be more than 5% of the patients in the chemotherapy arm, as we can see, the GI side effects like nausea, constipation, and myelosuppression, anemia, neutropenia, thrombocytopenia were far more as compared to the atezo arm. Whereas in the atezo arm, the known side effects, immune side effects like increased in AST, transaminitis, pruritus, rash, and hypothyroidism was there. Next slide, please. Now, the updated analysis also favored with the primary analysis, and no new safety signals were observed with a longer follow-up. Next slide, please. Now, similar findings were seen with the adverse events in the updated analysis. Next slide, please. So coming to the recent NCCN guidelines, we all know this. So whenever we come across a non-small cell lung cancer with high PD-L1 expression, whether it's an adenocarcinoma type or a squamous cell carcinoma type, we can prescribe the patient atezolizumab monotherapy in both the indications. Now coming to the ESMO clinical practice guidelines, they are also very much similar. In high PD-L1 expression, we can give either pembro or atezo, and in PD-L1, whenever the PD-L1 expression is less than 50%, we can combine atezo with chemotherapy. Next slide. So to summarize, in IMPAR 110 trial, atezolizumab represents a promising first-line treatment option in patients with high PD-L1 non-small cell lung cancer. It's a positive study that demonstrated statistically significant and clinically meaningful improvement of overall survival in the high PD-L1 expression wild-type population versus platinum-based chemotherapy. The hazard ratio was 0.59 and was significant. And high PD-L1 expression wild-type population, atezolizumab showed meaningful improvement in the PFS, overall response rate, and duration of response versus chemotherapy. The safety profile of atezolizumab was consistent with prior observations. No new or unexpected safety signals were identified. Immune-mediated adverse events were generally very low grade, and atezolizumab had a favorable safety profile compared with the chemotherapy, and the safety data was consistent with those from a pooled atezolizumab monotherapy population. Patient treated with atezolizumab had a longer treatment exposure, that is a longer duration of response, than patients treated with chemotherapy. Thank you. Thank you so much. Thank you so much. Sir, you need to unmute yourself.
So you need to unmute yourself, sir.
Yeah.
Oh, sorry. So thank you very much. That was a nice presentation. And previously we had only pembro with more than 50%, especially in squamous. Now we have both the things, that pembro as well as atezolizumab in this. And we are conversant with the handling of this drug. One thing I want to say is that anyone who's using this immunotherapies should be conversant with the side effect and how to deal with those side effects. That is one. And secondly, if it's a rapidly spreading disease, in that whatever PDL expression is there, we should add chemotherapy in those settings. Otherwise, it is a wonderful presentation, and we have enjoyed the presentation. Any question or anything I think that not much. So I hand this mic to my co-chair, Dr. Raman, please.
Thank you, Dr. Rajeshwar. It is my pleasant duty to now invite Dr. Jagdeep Singh, who is a consultant in American Oncology and Daran Medical College as a faculty there. And he's going to talk more on management of MET, this 14 skipping mutations, how to tackle it, and what is the role of capmatinib. Dr. Jagdeep, please.
Thank you, Raman sir. Thank you, Ashwin, for giving me a chance to on this platform. So shall I start now, sir?
Sure.
Sure. Thank you. Is my screen visible? And please let me know, is it the slides are moving?
Yes, sir. Yes, sir.
Okay, thank you. Thank you so much. Thank you. So today's topic will be on the MET mutations in the adenocarcinoma lung. Basically, it is like unlocking the unmet need in the MET mutation in the NSCLC, and the drug we now it is available with this is a capmatinib. So the most important thing regarding the MET mutation in NSCLC is that it is reported to be mutually exclusive to other established molecular drivers, including the EGFR mutations or the ALK translocation. And basically, there are two types are seen. Either it is a splicing or it's a amplification. So this is basically a drug which acts more in the patient with the splicing. So MET mutation, the splice set leading to exon 14 skipping result in a MET juxtamembrane gain of function alteration. Originally, it was discovered in the small cell and later in adenocarcinoma and non-small cell lung cancer. And this mutation of this splice siting is approximately 3% in the adenocarcinoma and approximately others of 5 to 22% in the other sets of NSCLC. And this MET exon mutations are linked to the older age patients. And in this graph, we can see that approximately MET exon mutation is seen in the approximately 3%, while amplification is close to 5 to 6% of the patient, they have the MET amplification. So just to give just a brief idea what exactly exon skipping means. So if you see in this MET gene, this exon 14, there is a splice site, and there ultimately forms an aberrant mRNA, which leads to a aberrant protein, which result in the activation of the one. While in case of MET amplification, if you can see, there is more of this gene at that amplified rather than of any splicing. So MET exon is associated with more of worse survival, and it's found to be an independent prognostic factor that predicted a worse survival outcome in patient without MET mutation. So if you see the curves, the patient with the MET mutations, they have a poor outcomes as compared to the patient who are MET negative. And these patients who are MET exon positive, they have a poor response to the immunotherapy. In a retrospective analysis of a 147 patient which is having MET exon mutation, 24 patients received immunotherapy and they were available for the responses. And you can see that only 17% of the patient had overall response rate with median PFS was only 2 months and OS was 8.2 months. This individual case report suggests that pembrolizumab may not be as effective in the NSCLC patient, even they are having high PDL expression, but if they are having MET exon mutation positive, the result may not be as good as in other patient without the MET. So this MET inhibition that can prolong the survival in the patient who have the MET mutated stage 4 NSCLC. And in a retrospective study of 148 patients who have a MET mutated metastatic NSCLC and who were treated with this MET inhibitor, they had a prolonged survival as compared to the other patient who received the other form of therapies other than this MET inhibitors. And overall survival in the patient with the MET mutated stage 4 NSCLC was approximately 8.4 month patient who never received a MET TK, and 10.5 months patient with the MET mutation only who received treatment, and 5.2% patient who have MET mutation as well as a concurrent amplification. That is both, that is splicing and amplification is present. And of course, the patient who received this TK inhibitor, 24.6 months was a survival outcome in the patient of those. So if you see the median of the patients who were stage 4 patient who received a MET TKI, it was approximately close to 8.1 months. But the patient, who never received a MET TKI, but the patient who received the MET TKI, the median overall survival was 2.6 months, 24.6 months. So there was significant difference between the overall survival patient who received this MET inhibitor as compared to the other patient who never received MET inhibitor or maybe on other forms of therapy. So what is unique with this drug? It is a selective MET inhibitor, and it is an oral ATP competitive, highly potent selective, and is of course a reversible inhibitor of the MET kinase. And it has a 10,000-fold sensitivity, high selectivity for MET receptor kinase. And the most important thing why it is more coming into the importance of this thing is that it crosses the blood-brain barrier. In the preliminary study, it was shown that it has some brain activity. And this potent blockade of this MET activation in cell-based functional biochemical assay as well as the in vivo models. So compared to the other agents, like we can see that crizotinib or other this savolitinib, tepotinib, and cabozantinib, this MET inhibitor, that is campanitinib, that has most potent against the MET exon 14 splicing. So this was one trial, Geometry Mono 1. It was a phase 2 trial, and it was done to evaluate the safety of single agent campanitinib in the patient who are having either stage 3B or 4 NSCLC. And any histology, either NSCLC or a small cell, this adenocarcinoma or squamous cell, but they should be EGFR wild type, ALK negative. And MET dysregulation means either there is mutation in the exon 14 splicing or amplification, both are included, with a COG-PS less than 0 or 1, less than 1. And all the patient, they must have this MET exon 14 mutation. So basically, initially this study was of 5 cohorts, and later it was expanded to include the cohort 6 and 7. And in the cohort 1, 2, 3, they are all pre-treated. And cohort 4 was pre-treated patient with a MET exon 14, regardless of MET GCN. GCN means gain of copy number, means without any amplification. Concurrent amplification was not there. So all other things were that cohort 1, 2, 3, they were pre-treated patient, but with the MET gain copy number, and who are having high copy gain number that is more than 10, they have a high response to the treatment. So similarly, the cohort 5 was treatment naive, and in this again 2 subsets were there. 5A, that is having only gene amplification without any MET exon 14 splicing, and MET exon 14 regardless of the amplification. So basically what they designed a population cohort in which the primary was the patient who were having MET exon splicing, but they can have amplification or can be without amplification. But who had only amplification, they should not have the concurrent exon splicing along with. So they basically want to check whether this splicing, irrespective of this concurrent amplification, has a better outcome with this campanitinib. So treatment of the drug was 400 milligram BD. So the overall, the endpoints of the study was that overall response rate as a primary objective, and the secondary objective was a duration of response. So basically they compared the 2 cohorts, that is cohort 4 and cohort 5B. 5B was treatment naive, and of course, if you can see, cohort 4 patient, they were pre-treated with MET exon 14 regardless of amplification, and 5B also MET exon 14 splicing regardless of MET amplification. So basically either pre-treated or treatment naive, and MET exon 14 splicing should be present regardless of the amplification. So in this patient, this various characteristic of age, gender, they were basically matched. So ECOG status, they were all the parameters, they were basically matched, and majority were adenocarcinoma, both subsets. And brain line metastasis was present approximately in 15% of the cohort 4 and approximately close to 10.7% in patient of cohort 5B. And concurrent amplification was seen in majority in the patient with the cohort 4 as compared to the patient with the cohort 5B. So the patient with the cohort 4 have already received chemotherapy, but the cohort 5B was treatment naive, and it was found that patient who received the chemotherapy in the cohort 4, majority were the platinum-based chemotherapy, either first line or second line. And other primary therapies can be that is immunotherapy, that was seen in approximately 27%. And first line was 13%, and second line was in 14%. And approximately 4% of the patients, they received the bevacizumab. So the response rate in these patients with the cohort 4, they showed a clinically meaningful responses in patients who were pre-treated with a MET exon 14 splicing advanced NSCLC. And if you see, they approximately with the investigator as well as the independent review committee, the overall response rate, that is partial response, were close to 40 to 42% in both sides. And the overall response rate was 40% in the independent review committee as compared to 43% with the investigator. So patients who have received pre-treatment with either platinum-based or either immunotherapy with exon 14 splicing with or without amplification, the overall response was seen to be close to 40%. So in the patient who were treatment naive, in this, the overall response was close to 67% in the independent review committee, but it was 60% in the investigator. And majority of the patient, they have a partial response. And according to independent, only one that patient had a complete response. So if you see the patient who are treatment naive, they have a better overall response as compared to the patient who were previously pre-treated with either platinum-based chemotherapy or immunotherapies. So this shows that cohort 4 and cohort 5B, the tumor response shrinkage as per the independent review committee, and they have shown, it has been seen that deep responses were observed in the majority of the patients who received this capmatinib as compared to the patient who were receiving either in pre-treated or in the treatment. So both have a good response, but it was more deeper response was seen in the both, but overall response was more in the treatment naive. Similarly, the duration of response, it was the median duration was 9.7 months in cohort 4, that is pre-treated, and in cohort 5B it was 12.6. So treatment naive patient did better with the capmatinib as compared to the patient who has already received pre-treatment with the chemotherapy or immunotherapy. So similarly, the progression-free survival was higher on the patient who were treatment naive, that is 12.4 months as compared to 5.4 months, the patient who were pre-treated with the chemotherapy or immunotherapy. This plot, the swimmer plots, they show that responders rapid and durable responses was seen across both cohorts, that is either pre-treated or naive, with the onset occurring at approximately the first tumor evaluation and of the initiating of capmatinib in 82% of the patient in cohort 4 and 68% in the cohort 5B. So the patient who were pre-treated, they have a better durable and rapid response, means they achieve a better response rate, though the PFS and the duration of response were less, but the achieving of that response was more in the patient who were pre-treated as compared to the patient who were treatment naive. So similarly, as I have already told that this drug has a enhanced brain activity, and it was seen that patient in the treatment, this is cohort 5B, they have a confirmed activity against the brain, and the 13 patients were available with the brain mets at the baseline, and approximately 50% patient had an intracranial response, 4 had a complete resolution of the lesion, and the rest 3 had some partial response with some of the disease were stable. So intracranial responses were as fast as response in the extracranial lesions, and all the patient in the brain who had this brain metastasis had an intracranial response at the time of the first evaluation. That is approximately 6 weeks of start of the treatment. And approximately 12 patients had some intracranial disease control also in these. So if you see, it means all the 13 patients who were evaluated for this, other than one patient, some majority of the patient had some response to those patients. And if you can see in the right side of this slide, this A1 and B1, you can see that lesions were there, which was not visible later on. So approximately 50% of the patient, though it's a very small number, but as per the data, whatever is available, 50% of the patient had a good intracranial response, they had complete resolution. So the cohort 4 and 5B, they have a greater tumor shrinkage by this MET alteration, who had this gene copy, that is amplification or either splicing. They have a good deep responses. It were observed in both, and it was independent of type mutation, either splicing or amplification. So both cohorts showed some responses, and of course, they were very deep. So the updates from this geometry mono 1 study, that is, we were mainly comparing cohort 4 and 5B, which were later expansion of cohort 4 was of this 6 and 5B was of 7. And it showed a greater overall response rate, the patient who had this MET mutation, and the duration of response was also there, and deeper and rapid responses was seen. That was some different in the cohort 4B as compared to the 5B. So overall, 66% response rate was seen and 98% disease control was seen in the first line patient who are receiving treatment. That is cohort 5 and cohort 7 was treatment naive. So if you see in both sides, that it is 7 is basically expansion of this 5B. So both have a good overall response rate close to 68%, 67%. And duration of complete response is approximately, disease control rate is close to 95 to 100%. So very high overall response rate and disease control rates in treatment naive patient from the cohort B was confirmed in the expansion cohort 7. And there was a consistent responses between this independent review committee and investigator in the patient who are treatment naive with the MET exon 14 mutation in the cohort 5B. Similarly, the patient who had this response, that is who were pre-treated either cohort 4 and with the expansion cohort 6, they also have a good overall response rate. Though it was 40% in the cohort 4, but it was close to 50% in the cohort 6. And why this was? Because the cohort 6 was second line setting. That is patient who had received only one line of treatment. But in cohort 4, either second or third line, that was the overall response rate was little less. Even the patient who were receiving in the third line, they were showing some responses. That's why it is a bit less magnitude as compared to the cohort 6. And disease control rate was also more in the cohort 6, that is 90%. And as compared to patients in the cohort 4, which was 78%, which is again explained by because the patient were getting, some of the patient were getting in the third line as compared to only the second line. So either second line or third line campanitinib, if you give, there will be overall response rate close to 40% with the disease control rate of approximately 80%. So the majority of the patient who were pre-treated had a response at the first evaluation after initiating campanitinib with durable responses. And this rapid and durable responses were observed irrespective of the line of the therapy. In a patient with response to campanitinib, the majority of the responses occurred within the second month of starting treatment. And median duration of response was 12.6 months in first line, 8.4 months in second line, and 9.7 months in the second or third line. And similarly, it follows with the PFS also. It is best if used in the first line as compared to second or third line. So a clinical meaningful median overall survival of 20.8 months in the first line, that is treatment naive, as compared to 13.6 months in either second or third line, that is cohort B for observed. So patient who had received this campanitinib, the majority of the side effects were like peripheral edema, which is most commonly seen in approximately 50% of the patients in all grades, and approximately 9, that is 10% of the patient that was grade 3 or 4, followed by nausea, followed by vomiting. And of course, we have to check for the creatinine also as seen in this trial. So adverse event of any grade and irrespective of the study drug ratio were reported in approximately 50% of the patients. So conclude that the primary efficacy results of this expansion cohort 7, that was treatment naive, that is cohort 5B, are comparable to those seen in the cohort 5B, and both in treatment naive with the MET exon 14 splicing with or without concurrent amplification. And in the pre-treated, the overall response rate close to 50% in the second line and close to 40% in the second or third line. Meaningful median OS of 20.8 months and 13.6 months were observed in the treatment naive and pre-treated patients, and thus demonstrating a long-term survival benefit of the campanitinib in this patient population. And the manageable safety profile of this drug remains unchanged based on the safety result from the Geometry Mono 1 study. And the updated results reveal further a confirmation of MET exon 14 as a targetable oncogenic driver in NSCLC and strengthen the evidence for the campanitinib as a valuable target treatment option for the patient who are having this MET exon 14 mutation in the NSCLC. So thank you, sir.
You have to unmute yourself, sir. You're muted, sir.
Okay.
I'm sorry. Thank you very much, Dr. Zizdi, for such a nice presentation. And I hope in time to come, there will be more comparison between the phase 3 trials being done and comparing with the previously available TKIs. And I hand over to Dr. Rajeshwar once again.
Thank you, sir. And now we proceed on to the next topic. We have Dr. Ashwin, our host today, and there is no time limit for him and being a host. So He'll be talking on another important mutation we have, that is BRAF mutation. And as we know that he's head of medical oncology at CMC Ludhiana as well as Oswald Hospital Ludhiana. So over to Dr. Phillips.
Thank you, sir. And without wasting much time, I'll go on to my presentation. Just to reinforce the fact that both Jagdeep and I have slightly tougher topics, because these are the drugs that we don't commonly use and the mutations that we commonly don't chase, and the data is never in these two subsets are not phase 3. So with that, I'm going to talk about BRAF mutation and the role of BRAF inhibitors in lung cancer. So what I'll be looking at is what is important is to check for the BRAF and why we should check for the BRAF mutation. How do we check for it? And the data about dabrafenib and trametinib in this subset of patients. Now, BRAF, as all of you know, is an important part. It helps you. It is a part of your RAF-MEK pathway. And when you have activation of this pathway, there's cellular proliferation and activation of your tumor cells. That's in a nutshell. But BRAF mutations are most commonly seen in melanoma, where the data is very good. In colorectal, around 10% of the patients, thyroid. But in non-small cell lung cancer, it is around 2 to 3%. So there are various studies which have looked at the incidence and prevalence of BRAF mutations. Overall, including both small squamous and adeno, the incidence is around 1 to 3%. If you look at adeno exclusively, it's around 5% in some series. And if you look at the squamous subset, the Cancer Atlas genomic study showed that in even the squamous subset, there were around 3% of patients who had BRAF mutated. Now, why is that important? So when you have BRAF mutation, like I said before, the studies have shown between 1 to 4%. An important thing to understand is this BRAF has this, when you do an NGS or report, you get a BRAF, you have to check whether it's a V600E mutation or a non-V600E mutation. Because most of the studies or most of the data was based on the V600E mutation. So always recently we had a discussion in one of the groups where I had a patient. It took me quite a bit of time to understand actually if the mutation was V600E or not. So that is very important, because most of the studies or most of the epidemiological data have majority of the patients having a V600E mutation. Now, compared to other subsets like your EGFR, where we know that women, non-smokers, Asians have a higher EGFR population. If you have an ALK population of ALK positivity, you may have asymptomatic brain mets. The data to say whether whom to test for BRAF isn't that great, because you really don't know which are the subset of patients that you would have BRAF positivity, because the numbers of patients are low. So if you look at this little bit of data that you have, that they may have a female predominance, most of the patients may have had a history of smoking. This is what we've seen from the retrospective data. Now, like what I said is before, that around, if you look at the BRAF mutation as such, around 50 to 70% of them would have a BRAF V600E mutation. And compared to the non-V600E mutation, the data isn't very robust. So if you look at a retrospective series of around 1,000 patients with non-small cell lung cancer, BRAF mutation was present in around 4.9% of the adenocarcinomas. In that, 21 of the 37 BRAF mutations were V600E mutations, and the rest of them were not V600E mutations. Now, why is this important? When you have a BRAF 600E mutation, that cancer is supposed to be more aggressive. They have worse outcomes. That is again retrospective. Because this data is all retrospective. So compared to those patients who are wild type versus the mutation types have not done well. Post-surgical resection, the outcomes have been poor, and compared to the wild type and as well as the non-wild type. Now, for the patients with metastatic disease that we commonly see, again, what we've seen in the retrospective studies is that compared to the other subtypes, these patients don't do all that well to platinum-based chemotherapy, which is the standard of care for most of the patients who do not have a targetable mutation. So here, what we see is that compared to those subset, chemotherapy probably doesn't do all that well in this subset of patients who have a BRAF activation. Now, if you look at this data, why it is important is that what we see is that this is again retrospective data showing that majority of the patients received one line of chemotherapy. But if you look at the second line, 57% of the patients received supportive care, showing that after you give one round of chemotherapy, the disease either progresses very badly or the patients don't tolerate and they rapidly deteriorate. Now, if you look at the French registry study, it showed that most of the patients, because they had a BRAF mutation, received some sort of a doublet chemotherapy. We also have the SEER data, the SEER data which looked at patients who had driver mutations and those who did not get driver mutations. Those patients who did not get driver mutations had a 1 year lower survival than other patients who had a driver mutations and who could be targeted. So that is a very important factor. That the very fact that we have a driver mutation and we can target it is the main thing that is changing the way we treat cancers nowadays. Now, the current guidelines is quite straightforward. When you have a patient with adenocarcinoma lung, you check for your mutations. At least minimum you check for is ALK cross EGFR. The NCCN now recommends a larger spectrum of testing, but at least you check for that. And if you can, you try to give a doublet chemotherapy with the platinum based. Irrespective of your PD-L1 expression, now you have approval to use pembrolizumab upfront or atezolizumab with bevacizumab upfront, and followed by which you put the patients on maintenance therapy. On progression, depending on whether you have exposed the patients to immunotherapy, you can bring in the immunotherapy. And the patients who are unfit go for bed supportive care. Now, traditionally, when we were also postgraduates, the dictum of training was you check for EGFR, then you check for ALK, then you check for ROS, and you take it forward. But now the NCCN also strongly recommends that you do parallel testings to save time and to find out which are the patients you can target. So there's always a debate about how should you do it, which is the best way. In practice, I would generally recommend that if you can, you could do a targeted multi-gene testing to look at the target mutations. At least check for EGFR, ALK, ROS. Preferably try to check for all of them, EGFR, ALK, ROS, BRAF, PD-L1, HER2, RET, MET, and KRAS. We may not be able to target all these patients, may not be able to afford, but it definitely gives you a prognostic prevalence, because sometimes these patients do very badly and you can actually prognosticate the family. And we've recently done that to 2 to 3 patients. We knew they were not working because this mutation is positive and the family understands that this is the reason that it is happening. So that is prognostically, it is also important to look for all these mutations. Now, this is what the ESMO and the NCCN both recommend, that they strongly endorse broader spectrum testing so that you can actually cover as much as you can. You don't have to do a foundation one testing for all this. You can do a limited panel NGS testing to find out what are the things that you can target and not target. Now, like we said before, this BRAF is peculiar because the data is limited and this is a low subset of patients. So there is nothing much you can say that whether it's an elderly patient, the sex of the patient. Most of the patients who are on these retrospective data have had a history of smoking. Now, understanding the fact that, as I said before, we need to find out whether it's a V600E or not is also very important in this subset of patients. You need to identify your patients. Now, coming to the clinical data, why do you have this? So we've already found that there's a mutation. Now we need to see how we can target it. So you have 2 things that are approved right now. You have dabrafenib and trametinib. Dabrafenib is a selective RAF inhibitor. It is a reversible protein inhibitor. Trametinib is a reversible MEK inhibitor. So understanding the pathway is important. The MEK comes down the RAF. So when you give a monotherapy, after a period of time, what you've seen in melanoma and colon is that there can be activation of the MEK pathway. So a doublet is now considered a better to give so that you can block both the pathways and have a better response rates. So if you look at the DCJ approval right now, you have approval for it for advanced patients with non-small cell cancer who have a BRAF mutation. This is what I explained before, the importance of having a doublet. In melanoma, what you saw is that they had good responses as a monotherapy, but over a period of time, the responses are lost because of the downstream activation of the MET inhibition. So it is important to inhibit the MET as well. And this helps you to have a synergistic action and delay the resistance of BRAF inhibitors in animal models. And this is why BRAF, as you continue, you're going to use encouraged to use a doublet inhibition than a monotherapy in this subset of patients. Now, this is a phase 2 study. Again, the reason for a phase 2 study was because the patients were low. They were trying to look at they did not compare it with the standard of care. So what you looked at is in this patient was, in this subset of patients was, it's a BRF 113928 study. This is a multi-cohort, non-randomized, open label, and it's a phase 2 study. In this, which they had patients with stage 4 lung cancer who had a BRAF mutation positive and a good performance status, who had not received this subset of treatment before, patients who had symptomatic brain metastasis and who were non-stable were excluded. You had 3 cohorts. Cohort A, which looked at patients who had received platinum-based chemotherapy in the past, and they were given monotherapy with dabrafenib. The cohort 2 had patients, or cohort B had patients who had got multiple lines of chemotherapy, but here they gave a doublet. And cohort C was a treatment-naive patients who were given the doublet. Now, the primary endpoint was the objective response rate, and which was again assessed by an independent committee. The secondary endpoints was the PFS, the duration of response, the overall survival, safety, and the population kinetics. Now, if you look at the cohort A, what you see here is that something striking, which is again retrospective to look at it, is that majority of the patients were smokers or had some history of smoking. And as expected, majority of them had adenocarcinoma histology. And most of the patients had received at least 1 or 2 lines of therapy before they had been put onto the study. This cohort B again was similar. Majority of them histology was adenocarcinoma. They were smokers and at least had received 2 lines of previous therapy. So this subset had received both the MEK and the BRAF inhibitor. Now the cohort C is what the patients whose treatment naive, who's not been exposed upfront. Again, all of them had adenocarcinoma. Again, the incidence of smokers was slightly on the higher side. Now, this is a phase 2 study, and as I explained before, there were 3 cohorts: the monotherapy in the patients who were previously treated, the cohort B with the doublet in the previously treated, and the cohort C, the treatment naive patients. Now, what you see in the cohort A, which had around 78 patients, which is more than what they really required, was that the objective response rate was around 33%. The disease control rate, which included a CR, partial response, and a standard and a stable disease, was around 58%. Now, the duration of response was 9.6 months, the PFS was 5.5 months, and the median OS was around 12.7 months. This is for the monotherapy. Now, the cohort B, again, if you look at the objective response rate, was around 63%. The disease control rate was around 79%, and the duration of response was around 9 months. If you see at this plot, you can see exactly what the 63% of objective response rate shows that the activity of these drugs to actually give a response rate in these tumors. Again, showing you in this patients who were previously treated, the median duration of response is around 9 months, both by the investigator and the independent review, showing that these were important. At 11 months, when they looked at the data, 50% of the patients were still ongoing when they were looking at the data cutoff. So that is also important, that there were patients who were being treated and were responding to the treatment. Now, if you look at the cohort C and if you look at the doublet or the cohort B, you see that the PFS was around 9.7 months. Or around 8 months if you look at the independent review, and this is showing you that it was almost more than the double of what the monotherapy was, showing that fact that double blockade would have been better than a single monotherapy, showing you that the theory was true, that you better block the BRAF and the MEK inhibitor down to get a better response and a duration of response. Now, coming to the cohort C are the patients who were treatment naive, who had this mutation. Again, 64% objective response rate, both by the independent assessment and the investigator. The disease control rate is around 75%, and the duration of response is around 10.4 months. If you look at the independent assessment, it is around 15 months. Again, at the data cutoff, what you saw is 31% of the patients were still receiving treatment. Again, if you look at this plot, you can see the response rates are remarkable. 64% patients had an objective response rate, and that means they would have had symptomatic disease improvement as well.
And if you look at Ashwin, sir, you need to conclude, please.
Yeah, so with that, we would like to say that this was the standard of treatment. And again, in the subset of patients, you had around 10 months versus 5.5 months. And coming to the toxicity, what you saw in the toxicity is majority of the patients had pyrexia. And what is something you need to explain to the patients, that pyrexia is something that is going to happen. And there is a step ladder pattern to check the pyrexia. If you have pyrexia, you need to go step 1, step 2, stop your dabrafenib immediately, wait for it, look for hypertension, any cause of infection, sepsis, bring in your corticosteroids if required. And if that is still not improving, you step down your therapy in the subset of patients. Again, the starting dose is 150 mg, that is around 50 mg tablets, and it is taken twice a day, and your trametinib is taken once a day. The safety profile is relatively similar. Important thing is to take in point is that pyrexia. So with that, I would end up my topic. And like Dr. Rajeshwar said, it is unfair that I didn't get the benefit of being the host and I got my Thank you, sir.
This is the organizers have intervened in this. Anyway, this was a wonderful presentation. And you see, testing for all very, very difficult in clinical practice. I know tissue is always been an issue, as well as we have liquid biopsies for others, but to get the full panel of liquid biopsy, more than 1 lakh rupees, is very difficult to ask patient to do. So BRAF is important, and what is more important is that we should have V600E mutation should be there in that. And apart from that, both BRAF as well as MEK inhibition is required. So thank you very much. That was a lovely presentation. And I hand over the mic to Dr. Arora for further.
Thank you, Dr. Rajeshwar Singh. And it is now my pleasant duty to invite Dr. Kaushal Kalra from Safdarjung Hospital, New Delhi, to share his experience on durvalumab in unresectable stage 3 NSCLC. Dr. Kaushal, please.
Yeah, good evening. Good evening, sir. Thank you to giving me this opportunity. Now, today I will tell about the experience sharing on the durvalumab in the unresectable stage 3 non-small cell lung cancer. So first we'll come on to this thing, Globocon data in 2020 in India. It's in both sexes ologies, lung cancer is the fourth most common cancer, while in the male, it's the second most common cancer, around 8%. Now come to the staging, because I have to explain the stage 3 NSCLC only. All of us know this thing, staging. T1 is less than 3 centimeter, T2 3 to 5 centimeter, T3 5 to 7 centimeter, T4 is more than 7 centimeter, N1 is ipsilateral pulmonary hilar node, N2 ipsilateral mediastinal subcarinal, N3 is supraclavicular or contralateral nodes. Similarly, M1A is the malignant pleural effusion or this thing separate tumor nodule in the contralateral lobe. M1B is single extrathoracic mets. M1C is the multiple extrathoracic mets. Now we have to come to on the stage 3A. 3A we can see if it is N2, T1 to N2 is stage 3, T3, T4 with N1 is stage 3A. If it is N2, it's stage 3B. If it is N3 with the stage 3, T3, it's N3C. Similarly, T4 and 0 is the stage 3A, and T4 and 2 is stage 3B, while T4 and 3 is stage 3C. So 3C is the new definition that reflects a larger tumor with more advanced nodal involvement. Up to stage 3A, it's a resectable disease. You can see only 16% patients are resectable. Stage 1, stage 2, stage 3A, while the most of the patients comes under stage 3B and stage 4. That is around 84%, which are non-resectable. Now we come on the management of the unresectable stage 3 non-small cell lung cancer. So it's a multidisciplinary team determines the resectability and treatment path, included pathologist, radiation oncologist, medical oncologist, pulmonologist, and CTVS surgeon. For pre-treatment evaluation and diagnostic workup, pulmonary function test, bronchoscopy, including EBUS, PET scan, and pathological mediastinal node evaluation with the EBUS and brain MRI with the contrast. Treatment, definitive chemoradiotherapy is a standard of care for the stage 3 unresectable non-small cell lung cancer. Concurrent chemoradiation is the better than the sequential chemoradiation. Chemotherapy regimes that are being used with the radiotherapy in non-small cell lung cancer, it's a various chemotherapy regime. You can see cis-etopo, cis-vinblastine, cis-pemi, Praxate, and median OS is between 1 to 2 years with all these regime. Sequential regime also cisplatin, vinblastine, and TP is being used. So what is the unmet need in the stage 3 NSCLC? CCRT is the definitive curative intent, is the approach for the curative intent CCRT, but still only 15 to 25% patient reached up to the 5 year survival. 40% patient faces locoregional metastasis, while 50% distant metastasis. So median PFS is around 1 year, and 5 year OA is around 15 to 25%. Various trials have been conducted to evaluate the consolidation therapy following this thing CCRT, but there is no impressive data. Only toxicity only increased. There was no overall survival benefit after this consolidation therapy or targeted therapy or vaccine. So no benefit. Excuse me. So evaluation of the, just a minute. So evaluation of the treatment approaches for the unresectable stage 3 NSCLC. In 67, only radiotherapy was being given around 60 grays. In between 90 to 95, sequential CTRT was versus the RT alone. There was median OS was 13.8 versus 9.7 month, and 13% decrease in the death. 92 to 2006 concurrent CRT was compared with the RT alone. There was 3 years significant OS benefit was there. In 99 to 2006 concurrent CRT versus sequential CRT, the OS benefit of 4.5% at 5 years, and PFS benefit of 2.2%. So concurrent CRT is better than the sequential RT. After that, induction CRT was compared with the CCRT alone. There was no OS benefit. After that, consolidation chemotherapy or radiation therapy, target therapy being given compared with the CCRT alone or placebo, there was no OS benefit. Only higher toxicity were noted. So platinum-based CCRT as the standard of care. So improving outcome in unresectable stage 3 NSCLC, CCRT is the considered as a standard care of therapy for the patient with good PS, while sequential CRT remain an option for the patient for a marginal performance status. To improve the prognosis, further strategies like increasing radiation dose, induction, consolidation chemotherapy were evaluated in addition to CCRT, but as I explained, there was no significant improvement in the OS. So what come next? Outcome treating stage 3 NSCLC carcinoma with curative intent radiotherapy and concurrent carboplatin paclitaxel chemotherapy. Intent in stage 3 curative intent, but only 15 to 25% patient reached up to the 5-year OS, despite of being it's being used as the curative intent. So we went one step ahead. Specific study was done. The immunotherapy durvalumab. It's a phase 3 randomized, double-blinded, placebo-controlled, multi-center international trial. So stage 3 locally advanced unresectable NSCLC who had either good response, partial response, stable disease, or complete response following this CCRT were included in the studies. 1 to 40 days, up to 6 weeks post CCRT, patients were enrolled in 2 arms, 2:1 randomization. First arm, durvalumab 10 mg per kg every 2 weeks up to 12 months were given, and another arm placebo was given. Co-primary endpoint was PFS by BSR using RECIST and OS. Key secondary endpoints were ORR, DOR, safety and tolerabilities. So baseline characteristics were well matched between the both arms, including age, sex, disease status, stage 3, stage B, stage 3B, EGFR mutation status. Everything was well matched. Similarly, PD-L1 expression level, tumor cells less than 25% expression, more than 25%, squamous, non-squamous, smoker, non-smoker, former smoker, and radiation dose. So every factor was well matched between the both arms. So all patients received 2 or more OLP cycle of the platinum-based chemotherapy concurrent with the radiotherapy. Patient may have received prior chemotherapies more than one context. So most patients had received CCRT prior to the study starts. And out of this total 711 patient, 190 patient already received induction chemotherapy also. So updated 5-year overall survival, we can see it's a wonderful response we have seen. At 5 years, 42.9% patient overall survival, while in the placebo, approximately 33.4%. So it's a wonderful response we saw with the durvalumab. And median OS was approximately 4 years, 47.5 months with the durvalumab, while with the placebo, it's around 29.1 months. So durvalumab first and only approved immunotherapy to demonstrate approximately 43% OS at the 5-year. Similarly, updated PFS, also we have seen this thing 33.1% in the durvalumab arm, while it is 90% in the placebo arm. So it's the first and only approved immunotherapy to show sustained and durable PFS of the 33.5% benefit at the 5-year. So first subsequent therapy followed by, after discussion durvalumab, was chemotherapy in 41% patient of the durvalumab arm, while 54% of the placebo arm received the subsequent chemotherapy. So pattern of the progression, we can see this thing in placebo arm, approximately 64% patient progressed, while 2/3 of this, around 45% patient progressed in the durvalumab arm. Similarly, intrathoracic also 36%, only 36% in the durvalumab arm and 48% in placebo arm. And extrathoracic and intra and extrathoracic simultaneously, both, every progression was more in the placebo arm as compared to the durvalumab arm. Median time to progression in the intrathoracic progression, only intrathoracic progression was 2 years, 25 months in the durvalumab, while it is placebo only 9 months. So for 2 years, there was no progression in the durvalumab arm. Median time to progression after 2 years. The pattern of progression, the extrathoracic lesion, total 8% patient in the durvalumab arm and double 16% patient in placebo arm developed extrathoracic. So we can see in IT2 population, there is a more progression, extrathoracic progression, whether 1 lesion, 2 lesion, all are more in the placebo arm as compared to the durvalumab arm. Come to the safety profile, it's a well safe. You can see there's not much grade 3, grade 4 toxicity as compared to the placebo arm. And pneumonitis is there. It's grade 3, grade 4 pneumonitis was more in this thing, durvalumab arm as compared to the placebo arm. Total 33.9% developed pneumonitis or radiation pneumonitis. But very few patients developed grade 3, grade 4. So as per safety profile, in the patient received within 2 weeks of the radiotherapy durvalumab or more than 2 weeks. We compared these duration wise. So more radiation induced pneumonitis or any grade pneumonitis in the if patient received within 2 weeks of radiation durvalumab. 39.2% patient developed pneumonitis if they received within 2 weeks of the radiation, and only 32% developed if they received after 2 weeks of radiation, after completion of 2 weeks of radiation therapy. Another trial, when to start the durvalumab after the CCRT. So first real life data on durvalumab after definitive CCRT was done in the France, was similar to the Pacific trial, inclusion exclusion criteria, almost similar. And at the end of a CCRT, around 78.5% had partial response, 15% had stable, and 6% patient had CR. And within 2 weeks, only 4 patients received the durvalumab, while within 2 to 6 weeks, maximum patient 58%. However, 40% patient received after 6 weeks of durvalumab. And we can see the CR, PR, SD was similar to the Pacific trial. Around 10.5% patient achieved CR, 20% PR, and 43% stable disease. While in Pacific trial, it's 1.4% patient achieved this thing, complete CR, complete response, 27% partial response, and 52% stable disease. So objective response was noted in 28.4% patient who received durvalumab, while only 16% in the placebo arm. So the response was like that was observed in the Pacific study, despite almost 40% of patients starting durvalumab 40 days after chemoradiation therapy. So the hope for cure in the stage 3 NSCLC. 5-year survival is important endpoint. Optimal CTRT followed by immunotherapy should be standard of care in the all stage 3 unresectable patient, and converting stage 3 lung cancer into never progressing disease. So it's a good hope. So key takeaway, durvalumab demonstrated statistically significant and clinically meaningful improvement in OS and PFS versus placebo in the Pacific trial. Median OS was around 4 years and PFS was around 1.5 years in the durvalumab arm. 5-year OS around 43% in the durvalumab arm. Patient receiving durvalumab had a lower incidence of new lesion, including new brain metastasis, compared to the patient receiving placebo, and on 22.5% durvalumab and this thing 33% in the placebo arm. And median time to progression was around 25 months. Tolerability profile is well acceptable. Low grade pneumonitis is not a deterrent to the use of durvalumab. And after 6 weeks also, it can be used. Stage 3A, it's resectable. Stage 3B, it was controversial whether we should go for surgery or we can go for CRT. So it was always a controversial topic, but after this thing, we got this durvalumab. I think stage 3B, we should go for CCRT followed by the durvalumab. Thank you.
Thank you very much, Dr. Kaushal. And it was a wonderful presentation, completed well in time and with very clear mind. What's the message? And as with other drugs which have come recently, and we are discussing more of the points which are having some contribution, but this was where the largest number of patients can come. And other than financial, I don't know what will check us. See, there will be a question regarding that, the way osimertinib was used. And then there was a paper for erlotinib high dose intermittent with CNS involvement. Same thing, I believe, needs to be done, something to be done about it. Thank you very much once again. And I hand over back to Dr. Rajeshwar Singh, please.
Thank you, sir. And now we are moving to, I think we have covered most of the things in lung cancer, and only thing is left with that is the dual immunotherapy in lung cancer. So for that, we have Dr. Burhan Wani. He's a senior medical oncologist from AOI Jalandhar, and I request him to proceed with this topic. Thank you.
Sir, yeah, Dr. Burhan Wani, you are there. Can you please unmute, sir?
Just a minute.
Yeah.
Are the slides visible?
So slides are visible. If you can make it into the slideshow, that will be great. You are fantastic, sir. All yours. Over to you, sir.
Thank you, sir, for the kind introduction. At the outset, I would like to thank the organizers for giving me today this opportunity for presenting data regarding the dual IO therapy in the treatment of the metastatic non-small cell lung cancer. And I would like to say that this is coming up as another modality of the therapy, as we have previously, as other speakers have discussed about the other immunotherapy and the targeted therapies that are coming up as treatment options for metastatic non-small cell lung cancers. And this is another option in the management of the disease. So the presentation, my overview will be that basically about the unmet need in the advanced and non-small cell lung cancers, and what actually, how the overview of the cancer immune cycle and how these immune checkpoint inhibitors, they are making inroads in the management of the various malignancies. Then I will be presenting briefly about the data from the CheckMate 227 study and CheckMate 9LA study. And finally, I will summarize the things. So if we see in our country, almost 2/3 of patients of non-small cell lung cancers, they are diagnosed at advanced stages and have a very dismal 5-year survival of close to around 5%. So there still remains the need for alternative therapy in order to induce an improved quality of response, so that both the duration, as far as the depth and the duration of response is concerned, with the potential to prolong the long-term survival of these patients. So this is how in this setting there has come a role of dual immuno-oncology based regimen, and this is based on the studies. We have two phase 3 trials, the CheckMate 227 and the CheckMate 9LA, and I will be presenting the data for those. So coming first to the overview, how these actually the cancer immune cycle has a role in how this actually this works, and how these immune checkpoints inhibitor work at the various you can say at the various areas in this cycle. We know that we have two as of now the antigens. One is the CTLA4 and other is the PDL1. And as of now, we have the targeted therapies for both of these antigens, and they are clinically approved. And what we have seen that initially, whenever there is a malignancy, there is a release of these tumor antigens, and tumor antigen is updated and it is presented by the antigen by the dendritic cells, and there is a T cell priming and activation. And it is here there is a role of cytotoxic T cell antigen 4, which acts as at a very early stage. So it is actually, it helps in the priming and the activation phase, and which in turn results in the results in the immune response, and it upregulates the T cell activity and helps to create the memory T cells. So with this, there is trafficking of these T cells into the tumor tissue, and T cell infiltration occurs. Then there is a recognition of these cancer cells by the T lymphocytes, and finally there is the killing mechanism. And here comes the role of PD-L1 antigen. So PD-L1 antigen, it acts late in the immune response after the T cell has been activated. So if we see, if we are able to combine both the two drugs, where we are actually using a anti-CTLA-4 antibody at the outset, so that it can lead to better anti-tumor T cell responses, and finally the role of anti-PD-L1, where it can actually result in restoration of the anti-tumor T cell function. So this is the basic underlying mechanisms or the thought process which led to this combination of using the ipilimumab and the nivolumab in the combination in non-small cell lung cancers. So this is what happens, that the CTLA pathway, it results in it acts peripherally, it leads to better T cell infiltration, and in turn results in the infiltration of these T cells into the tumor tissue. And finally, in the tumor tissue, it is the PD-L1 pathway that helps in the killing of these cancer cells. So about the data, what we have this was the first of the two phase 3 trials. It was the Checkmate 227 trial, where nivolumab with ipilimumab versus the platinum doublet was compared as the first line treatment for advanced NLC patients. We had, based on this trial, they were the key eligible criteria was that patient had stage 4 or recurrent NSCLC with no prior systemic therapy, with no sensitizing EGFR or ALK mutation, with a PS of 0 to 1, and PD-L1 expression. So patients who had a PD-L1 expression of more or equal to 1% were included in the study. And the patients were also stratified as per the histology, squamous versus the non-squamous. So the randomization was done by 1:1, and the nivolumab, which was given at 3 milligram per kg body weight every 2 weekly, with ipilimumab, which was given at 1 milligram per kg body every 6 weekly, was compared with a platinum doublet chemotherapy, and the treatment was continued until disease progression or unacceptable toxicity, or up to 24 months. And the primary endpoints of the study, it was the OS. So we know that OS is always the endpoint which should be actually looked into, and which is the actual marker of how effective the response is. So if we see the two arms, they were well balanced between the two arms as far as the characteristics was concerned. And this is the data. Actually, this is the OS data. If we can see here that there was the patient who were on the double IO arm. They had, as far as Woodkey said, the OS, which was compared at 3, if you see that the 3 years, 33% of the patients were alive, as compared to 22% of patients in the doublet chemotherapy, and it was maintained. We can see that for the patient who were able to respond, they continued to respond beyond 4 years and beyond. And this is as far as the histology is concerned, the squamous and the non-squamous histology. Definitely for non-squamous histology, they had better as far as the survival data was concerned, but for the squamous as well. So squamous, it was even better, where it was seen that patients who were on doublet chemotherapy, the survival at 3 years was 24% for the IO arm, as compared to 9% for the chemotherapy doublet arm. So this is again one of the interesting slides, where we can see that patients who responded early and who are actually responding, and these patients continued to respond. So if the patient had responded very early to the 1 year, at the 1 year, they continue to have the response even beyond. So this is the beauty of the immunotherapy. We know that patients who are responding, they continue to respond for a long period of time. We can see here that the group, the IO group, 70% of the patients who were actually responding, they continue to respond, compared to 40% of the patients who for the chemotherapy arm. So the overall response, we say that patients with PD-L1 of more than equal to 1, overall response rate was 36.4 for the double IO combination, as compared to 30% for the chemotherapy arm. And this was the duration of the response. So duration of the response, again, we can see here, as I mentioned previously, that there was a continued benefit as far as the IO arm was concerned. So this was the adverse effects that was seen in the patient. Definitely for this sort of a combination, we will actually see more toxicity as compared to the single immunotherapy drug. So we had more of toxicities, which include the immunotherapy driven toxicity, which include the skin toxicities. They were more as compared to the chemotherapy arm. Then we had the GI toxicities were more, but majority of these toxicities were grade 1 or grade 2. There was fewer toxicities that led to the discontinuation of the drug. So this is again the efficacy data. Another thing that was seen, that patients who actually had to discontinue because of the treatment related adverse effects, these patients, once they were discontinued, they continued to respond once the drug was discontinued. So we can see here that patients who were discontinued early, 48% of the patients who were on the discontinued because of treatment related adverse effects, they continued to respond, compared to 33% at the 3 years. So based on this data, the NCCN gave a recommendation, category 1 recommendation for this dual IO based combination as the first line option for metastatic non-small cell lung cancer, which was seen across the histologies. And it was for the patients who had PD-L1 expression of 1 or more equal to or more than 1%. So this was the summarization of the same study that I mentioned. Then another study where they have tried to actually incorporate the same dual IO based therapy along with the 2 cycles of the chemotherapy that were given upfront in patients with the metastatic non-small cell lung cancer. And the aim of adding the 2 more cycles of the chemotherapy to the IO based combination was to actually allow a rapid disease control, while building on the OS benefit that was observed for the dual IO based therapy, as we have seen in the Checkmate 227 study. And it was already seen that in one of the studies that this regimen was tolerable. So patients for this study design, the patients, the eligibility criteria were stage 4 or recurrent non-small cell lung cancer with no prior systemic therapy and no sensitizing EGFR mutation or ALK alterations, and the patients were stratified as per the histology was concerned, PD-L1 expression of less than 1% or more or equal to 1%, and the gender. Then these patients were randomized to receive the nivolumab, which was given at flat dose of 360 milligram every 3 weekly, and ipilimumab was given at 1 milligram per kg body weight every 6 weekly, along with 2 cycles of a platinum doublet chemotherapy. And after that, these patients were continued on the nivolumab and ipilimumab based therapy. The other arm, they had the 4 cycles of platinum doublet chemotherapy. The IO combination was given for up to 2 years, or if there was any disease progression or unacceptable toxicity. And again, the primary endpoint of this study was the overall survival. So this was the clinical characteristics that were across between the 2 arms, and it was well balanced. So again, if we see can hear that once these patients who are on the doublet IO therapy along with the chemotherapy, if we see the survival, they were better as far as this combination with chemotherapy was concerned compared to the chemotherapy alone, and it was again sustained. And this was as far as the expression, PD-L1 expression was concerned. So it was seen that patients who had a PD-L1 expression of less than 1%, they again benefited as far as the survival of these patients was concerned in the arm containing the dual IO with chemotherapy. So again, it was seen that it was across, whether we had more than 1% or even more than 50%, these patients had a better outcome as far as the response, as far as the outcome to these therapy was concerned. So again, it was seen that patients, if we see the forest plot, that the various subgroups that was seen, they were seen that benefited across the various subgroups, which included the histology, presence of bone metastasis, if the patient had CNS metastasis as well, and across the various PD-L1 expressions that this combination benefited. So at 2 years, we can see that this combination arm compared to the chemotherapy, it nearly tripled the duration of response as compared to the chemotherapy alone. So again, this is about the toxicity. Again, it was seen that patients who had actually toxicity, they continued to benefit once the drug was discontinued as far as because of the various adverse effects that was seen. So this is the same data that once these patients actually were discontinued, they continued to respond as we have seen for the Checkmate 227 study. So this is about the various toxicities that we see in these patients. Predominantly, as we know that immunotherapy related adverse effects, they predominantly the most common the outset is the skin. Then we have the GI toxicity. Then we have the hepatic toxicity, and finally the endocrine toxicities that can occur. And majority of these toxicities were grade 1 and grade 2, and they were able to be we were able to continue it. And as we can see here, that majority of the toxicities that were seen, they were predominantly grade 1 and grade 2, and fewer of grade 3 and grade 4 toxicities were actually encountered. So to summarize this, that at 2 years, the OS, it was durable as compared to the chemotherapy, and the benefit, as I mentioned, it was seen very across the subgroups, including the PD-L1 expression and the histology. And the Checkmate 9 LA study, it demonstrated that dual IO-based therapy with 2 cycles of chemotherapy, it could be considered as a new first-line treatment option for the advanced NSCLC patients. So this is as far as the dosing is concerned for the 2 studies. In the Checkmate study, the nivolumab was given as per the body weight, 3 milligram per kg body weight, and every 2 weekly, and the ipilimumab was given at 1 milligram per kg body weight every 6 weekly, and it was given up to 2 years, or if the patient had or discontinued until if there was a disease progression or unacceptable toxicity. For Checkmate 9LA study, there was a flat dose of nivolumab was given at 360 milligram every 3 weekly, and ipilimumab was given at 1 milligram same dose, and 2 cycles of platinum-based doublet chemo were introduced. And this is what we had. As I mentioned, that for patients with metastatic non-small cell lung cancer, we can see based on the Checkmate 227 study, there was a durable 4-year OS of 29% versus 18% with chemotherapy, with a median duration of response of 23.2 months for the IO-based therapy as compared to the 6.7 months for chemotherapy. And for the Checkmate and 9LA study patients, the 2-year landmark OS was 38% versus 26% with the chemotherapy arm. Thank you. I rest my case over here, and I hand over the things to the organizers. Thank you.
Thank you very much, Dr. Burhanwani. I mean, I've yet to find a patient where I can give this 9LA type of a treatment, but I believe if we can, especially with patient with large tumor burden, with a good PS, especially it has got a very good response in brain metastasis also. And I think as we move, we are afraid of toxicity of immunotherapy, single agent and doublets are going to be more. And as we have more experience, I think this will come into our clinical practice quickly. And thank you very much. And I hand over the mic to organizer Dr. Phillips.
Thank you, sir. Thank you, everyone. So just wanted to conclude this event, and I wanted to thank everybody, especially the organizing team that supported us in this program, all the senior chairpersons who took part in it. Nobody even hesitated even to be a part of the event even one time. I want to thank all the faculty that took part in this event, and it's a huge encouragement. And for all the support that we've got, for all the sponsors that we had and help us to encourage to take part in these activities. We're looking forward for more events, and also want to, like Dr. Rajesh said at the beginning, is to get more of interaction from our own set of people in this part of the country, because I think our own data is very good, and it's important that we have our own data and share our experiences, because that is the best way to learn. Oncology is going to change dramatically. It has changed in 3 years that I passed out. I think in 10 years from now, patients will sit at home and tell us, I mean, patients nowadays don't want to come to you, because I've had patients on alectinib who don't want to come. They're doing so well that they sit at home and say that we're doing fine. So that is how it is going to change, and hopefully it will change for patients around us. So with that, I would like to thank on behalf of both my colleague, Dr. Ankur, and myself for helping us to have a good event. And I hope it is interactive, and I hope all of you are able to benefit out of this event. So with that, I'd like to sign off for the evening and thank all of you for being a part of this event. Thank you, sir.
Thank you. Thank you.
So thank you everyone from the organizing team, and stay safe, enjoy your dinner. Good night to everyone.
Bye-bye.